Friends, today we will see the treatment part of PCO patients. Okay. So as we already discussed about the polycystic ovarian disease, now we'll move on to the treatment part. As I've already told you, weight loss, that is 5% of weight loss can improve the menstrual irregularities of the patient. Okay, so if a patient is anxious to conceive, so what we will use? Anxious to conceive. We can divide this patient into two category. One for the natural intercourse, the other one is for IUI, and the next one is for IVF. We will not discuss about IVF, but we will see in non-IVF cases. So in natural intercourse and in IUI, the drug of choice for PCO patient is letrozole. 2.5 mg given twice a day for 5 days starting from day 2 to day 5. I prefer to give it between day 2 to day 3 only, not more than that, because already the selection of follicle is over. In case of IUI also we can use the same protocol and keep monitoring the follicles, that is from day 9th. See, if the patient has a cycle of around 35 days, so minus 15 days which is the luteal phase, so she may ovulate around 20th day of the cycle. So as we are given the letrozole, she may have her cycles ahead, and if the dominant follicle is there, she may ovulate early. So we have to monitor her from day 9 of cycle, usually alternate days, till the dominant follicle reaches around 18 to 20 mm, and then trigger. Post this we have to check for ovulation. Ovulation scan is must. If at all there is no dominant follicle, we can add HMG to it. The starting dose which I use is 150 international units on day 9, day 10, day 11. If at all, if you don't want to use in this cycle, then next cycle we can give on day 3, day 5, day 7, or day 7, day 9, day 11, depending on scan rate. Or if you are scared to give HMG, if you think that multiple follicles, if they grow, it will be difficult to handle and patient may land up in OHS. In that case, you can use extended letrozole protocol, where you can give letrozole 2.5 mg twice daily for 10 days, and you can do a follicular study. If no growth, then you can add HMG. So few people keep asking me whether ma'am we can give HMG is better or should we add FSH. See, HMG is always better because it has LH, which helps in follicular maturation. And as we all know, in PCO there is already high LH, but this LH is in abnormal form, which is not helpful for follicle maturation. So this is the protocol for PCO. If at all, what are the adjuvants we can use? Adjuvants for PCO patients. First thing is metformin. We can give up to 1500 milligrams, that is 5 mg thrice daily. This increases the insulin sensitivity decreases the androgen levels. If at all the BMI is more than 30 and patient is not responding to your treatment, then you can add steroids. That is prednisolone 5 mg daily night. You can increase up to 10 mg OD. Role of myoinositol. No, there is no role of myoinositols in polycystic ovarian diseases. So, you can put the patient on metformin or steroids. You can add HMG if they are not responding. In case if all this fails, then we have to think of IVF. If at all, during your non-IVF cycle stimulation, there is more than 3 follicles, till 3 follicles, 1 to 3 follicles is okay, and chances of OHS is less. If it is more than 3 follicles, then if there is no IVF facility, you can cancel the cycle, or you can refer to a IVF unit. Trigger non-IVF cycles, we usually give HCG 10,000. And for all these cases, luteal support is needed as PCO have low progesterone. You can give any form, either oral, vaginal, injectables. It is up to you. Okay, so this is what we follow for PCO non-IVF cases. Okay, then see you soon in the next class. Bye friends.